This recorded lecture will go over Chapter 22, Healthcare Adaptations for the Child and Family. When the child is admitted to the pediatric unit, a written informed consent is obtained for treatments that are provided. The parent, the healthcare provider who provides the information, and a witness must sign the consent. Every child admitted to the pediatric unit should have an ID bracelet applied. On page 498, you can read about some following list of positive do and negative do not measures that are applicable to the children's unit. A simple explanation and discussion with the parent or an age-appropriate explanation to the child should precede any nursing intervention. The parent should be allowed to assist whenever possible, and the child should be familiarized with the equipment to be used or even allowed to assist in simple aspects of the procedure when appropriate. The means by which the child is transported to the unit and other parts of the hospital will depend on age, level of consciousness, and how far the child must travel. Restraints can be used for infants and children to facilitate examinations or treatments and to maintain safety. The reason for the restraint must be explained to parents and the child. Restraint should be used only when necessary. To obtain accurate results, the organization of infant observation is important. On page 501, you can read about the 10 different areas of infant observation. Basic data collection involves casual observation without touching and interviewing the parents. The child's general appearance will indicate if his or her condition is serious or within normal limits. If the child is lethargic, prompt intervention by a healthcare provider is essential. The personal history survey will afford the nurse the opportunity to teach parents about the child's needs and about prevention of injury and illness. The admission history should include information concerning the child's usual health habits and practices regarding eating, sleeping, toileting, activity patterns, and use of special words and gestures. The immunization record should be reviewed and plans for future immunizations discussed. The physical survey includes a head-to-toe review that should be completed, at minimum, once every shift or once every clinical visit, even if the clinic visit is for a specific problem. Obtaining vital signs is a priority. Hypotension in an infant or child is considered an acute emergency. The fontanelle should be palpated. Bradycardia should always be treated as a medical emergency in infants and young children. Maintaining warmth during observation is essential for infants. An accurate kilogram weight should be recorded because the dosage of medications for infants and children is based on milligrams per kilogram of body weight. Pulse and respiratory rate will decelerate with age until the adult values are reached. You can see Appendix H to see normal heart and respiratory rates for various ages. Apical pulses are advised for children younger than 5 years of age. The child's respirations will be counted the same as for an adult. Common sites for measuring blood pressure in children are the brachial artery, popliteal artery, and posterior tibial artery. An abnormal blood pressure reading on 3 different visits is a cause for diagnosis of hypertension. All children should have their blood pressure checked and recorded using an appropriately sized blood pressure cuff. Auscultation of blood pressure is done the same way as for an adult, but instead with a pediatric stethoscope and a pediatric blood pressure cuff. Palpation is one of the oldest methods of measuring blood pressure, and it can be useful in newborns. Electronic or oscillometric measurement is a non-invasive type of blood pressure monitoring that ultrasonically detects motion of the arterial wall. The nurse should explain what is about to happen. Blood pressure will be lower in children than in adults. Any significant changes from previous readings and the current reading should be reported and documented. Many factors will account for variations in blood pressure measurements, including the time of day, sex, age, exercise, pain, and emotion. Fever differs from hyperthermia. Hyperthermia is an increase in the core body temperature that occurs with CNS impairment. Hyperthermia can result from a drug reaction, trauma, or environmental heating, like when a baby is bundled and left in a hot car. Fever results in increased metabolic demand on the heart and lungs, and children with cardiopulmonary disease will require antipyretics to minimize the increase in oxygen consumption that causes an increased demand on the heart. The fever is thought to be a protective mechanism that will aid in the recovery from infection. The pediatric body temperature can be measured via the skin or by oral, axillary, tympanic, or temporal methods to determine if fever is present. To evaluate the degree of illness in a febrile child, the response of the child to cuddling, in addition to alertness, hydration, sociability, and quality of cry, should be assessed and recorded. On page 505, you can read about the different methods for how to obtain temperature, as well as see the different skills on 505 and 506. Pain is a fifth vital sign that must be addressed in the plan of care. Weight must be accurately recorded in kilograms on admission. The way in which the nurse weighs the child will depend on the child's age. The child's height will be measured along with the weight. The head circumference should generally be measured on infants and toddlers and on all children with neurological defects. A urine specimen is usually obtained from the newly admitted patient. Urine collection directly from an ultra-absorbent disposable diaper could yield an inaccurate protein, pH, and specific gravity measurements due to chemicals in the diaper. Normally, little or no albumin should be found in the urine of a healthy child. Positioning the child for drawing blood is extremely important. Distraction and simple pain relief techniques should be used during any painful procedure and the infant soothed afterwards. The nurse will chart the site used, the name of the blood test, and any untoward developments. Lumbar punctures will be done to obtain spinal fluid for examination or to reduce pressure within the brain in conditions like hydrocephalus or meningitis. Normal spinal fluid is clear, like water. The procedure for children is essentially the same for that of adults, but the way in which the child is held can directly affect the success of the procedure. The most common over-the-counter medication administered by parents to infants and children is Tylenol. Understanding the differences in drug absorption, distribution, metabolism, and excretion between children and adults is essential to providing safe pediatric medication administration. In the neonate, there is an absence of free hydrochloric acid in the stomach. Therefore, medications that require an acid medium in the stomach for absorption may not be completely absorbed if the child is less than 2 years of age. Children less than 5 years of age have a more rapid intestinal transit time than adults. The larger the skin surface area will also increase the amount of absorption of a topical medication compared to adults. Poor peripheral perfusion in the young infant can slow IM drug absorption. Drugs will generally metabolize more slowly in the infant and young child compared to the adult. Morphine can be used for moderate to severe pain after surgery, and non-opioid analgesics should be used for mild to moderate pain. In infants less than 1 year of age, immature kidney function can prevent effective excretion of drugs from the body. Nurses must observe for toxic symptoms whenever medications are administered and must document positive and negative responses. Close attention should be paid to pediatric dose calculations. Instruction should cover 6 areas: the importance of administering the medication, the importance of completing the prescribed course of treatment, techniques for measuring the amount of medication to administer in each dose, techniques for administering medications to the infant or child, techniques for encouraging child compliance, and the importance of writing a schedule and documenting the administration to avoid forgetting or double dosing. The administration of medication by the mouth is the preferred method in children, but it's not always possible due to vomiting, malabsorption, or refusal. Children younger than 5 years of age cannot safely swallow tablets or capsules. Medication should never be diluted in formula or water because medications should be given in the smallest amount possible to assure the complete dose is consumed. The medication is never referred to as candy. It should be administered slowly, even if the child is crying. For infants, an oral syringe is an excellent device for measuring small quantities. Except for a few differences, the principles for administering nose drops, ear drops, and eye drops to children are essentially the same as for adults. Children's suppositories are long and thin compared to the cone-shaped types that are administered to adults. Some medications must be given by the subcutaneous route. The site and technique of injection can affect the absorption rate and the effect of the drug on the child. Because there are no large vessels in the recommended injection sites for children and infants, aspiration of IM injections is not necessary. IM injections will be administered into the thickest part of the vastus lateralis muscle in the anterolateral thigh of all infants. The ventrogluteal site will place the medication into the gluteus medius and gluteus minimus muscles, which are free of any major nerves and blood vessels. This site can be used for adolescents and adults. The dorsogluteal site is small and poorly developed in infants and children and should not be used for IM injections. Immunizations will often be administered via the deltoid site. Positioning the patient properly can minimize muscle tenseness and ease the procedure. Infants should be given a sucrose-sweetened nipple to suck on or should breastfeed during or after the procedure. The older child should be distracted. The needle should be inserted rapidly and the medication injected rapidly unless the package insert states otherwise. Rapid removal of the needle and mild massage or exercise of the extremity can increase absorption and comfort. The size of the syringe and needle will vary with the size of the child, the volume of medication prescribed, the amount and general condition of the muscle tissue, frequency of injections, and the viscosity of the drug. As a general rule, 1 milliliter is the maximum volume to be given in one site to infants and small children. Infiltration is a risk for children who are active, and the site should be observed hourly because infants cannot communicate burning or pain that can accompany infiltration. A pediatric arm borne should be used to restrain the extremity used for IV access, and the insertion site secured and covered to prevent tampering by the child or parents. Infusion pumps and syringe pumps should be used in pediatrics to control the administration of small volumes of fluid and prevent changes in the rate resulting from changes in position or activity in the infant or child. Monitoring vital signs, recording I&O, and tracking lab reports are essential nursing responsibilities. Hypoglycemia, hyperglycemia, and electrolyte imbalances can occur with the administration of TPN. Parenteral fluids are necessary when vomiting or loss of consciousness accompanies sickness or when the GI system requires rest. Diversional therapy can prevent the child from focusing on the IV tubing and using it as a toy. Pediatric IV sets will administer 60 drops per 1 ml. The infusion pump will sound an alarm every hour to alert the staff that the IV site must be assessed and the response of the infant documented. A Broslow pediatric emergency tape can be used to determine the length of the child and serve as a guide in administering emergency medications by correlating dosage calculation and equipment sizes for emergency use. The PD slide chart is another product that can be used to help reduce the number of medication errors. The PD slide system uses a disposable tape to measure from the top of the head to the heel of the foot of the fully extended leg. Most pediatric medications are prescribed in milligrams per kilogram of body weight per 24 hours. If there is any question, one should consult the charge nurse, the healthcare provider who wrote the order, or the hospital pharmacist. There is no average dose in pediatrics because the weight of the child could vary, and at different ages, the ability to metabolize and excrete drugs will be limited. Therefore, it's necessary for the nurse to calculate whether the ordered dose is safe. In addition to knowing the correct amount and route of a drug, the nurse should also be aware of toxic side effects that could occur. Drug reactions are therefore not as predictable as they are in adults. Drugs should be administered only by the route indicated. Table 22.4 on page 525 can provide a partial list of common drug-drug interactions. Table 22.5 will list some drug and food interactions. A gavage feeding may be ordered when an infant cannot take food or fluids by mouth, but the GI tract is functioning. When long-term feeding is required, a gastrostomy tube may be performed and a tube inserted directly into the stomach. A gastrostomy tube is used in infants or children who cannot have food by mouth due to anomalies or strictures in the esophagus, or who are severely debilitated or in a coma. Administering an enema to a child is essentially the same as for adults. However, the type, amount, and distance for inserting the tube will require modifications. An isotonic solution should be used in children, and the smaller the child, the less solution used. Infants and small children may be unable to retain the solution, so it may be necessary to hold the buttocks together for a short time. Any patient with a tracheostomy should be placed in a high area of visibility. The use of suction can be shown to the child with a glass of water, so that the child is then prepared for the unfamiliar sound. Nursing care of a child with a tracheostomy is a significant responsibility. There is a large supply of teaching aids and dramatic play material that can be made available. Puppets can be particularly valuable. Maintaining patency of the tracheostomy tube is of the utmost importance. Selection of a suction catheter is important. The nurse should choose one that does not block the tube during suctioning. The diameter should be about half the size of the tracheostomy tube. Suctioning should be done periodically and when necessary. Indications for suctioning would include noisy breathing, bubbling of mucus, and moist cough or respirations. The tracheostoma should be treated as a surgical wound, the area kept free of secretions and exudate to minimize the risk of infection. The nurse observes the patient for symptoms like restlessness, rising pulse rate, fatigue, apathy, dyspnea, sternal retractions, pallor, cyanosis, and inflammation or drainage around the incision. Possible complications include tracheoesophageal fistula, stenosis, tracheal ischemia, infection, atelectasis, cannula occlusion, and accidental extubation. An extra tracheostomy tube and the equipment needed for its replacement should always be kept in a visible, easily reached area at the bedside for use in emergencies. Additional nursing measures include frequent changes of position, the use of elbow restraints, oral feedings, and careful bathing to prevent water from entering the tube. Certain patients will be discharged with a tracheostomy. This is anticipated, and instruction and demonstration for the parents should begin early. All equipment used for oxygen therapy should be inspected periodically. Friction toys are to be avoided because the sparks of the toys could ignite the oxygen. Nylon or wool blankets should not be used. Prolonged exposure to high oxygen concentrations could be toxic to some body tissues. This is particular in children with pulmonary diseases like asthma or cystic fibrosis. Oxygen therapy will be terminated gradually. An increase in the restlessness and pulse rate of the respirations will indicate that the child is not tolerating withdrawal from oxygen-enriched environment. Oxygen should be administered to children as appropriate for age via an isolette, nasal cannula, mask, hood, tent, or tracheostomy. The desired goals include decreased restlessness and improved breathing, vital signs, and color. Emergency abdominal thrusts and back blows are recommended to dislodge food or foreign bodies from the airway. The nurse should not perform abdominal thrust on an infant because it could cause injury to the infant's abdominal organs. Children are particularly fearful of surgery and require both physical and psychological preparation at the child's level of understanding. Listening to the child is especially valuable for clarifying misunderstandings. Table 22.6 and 22.7 on page 533 will summarize the preparation for surgery and postoperative care. The nurse needs to know policies and best practices when a teen with body art is hospitalized.